Surveillance of SARS CoV-2 variant immune escape, clinical implications and management. The emergence of SARS CoV-2 variants with enhanced immune escape capacity has driven a 3.2-fold increase in breakthrough infections worldwide in 2023. Mutations in the spike receptor binding domain, RBD, reduce neutralizing antibody binding by up to 96% and alter T-cell epitope presentation. Accurate detection relies on a two-step algorithm of RT PCR screening, CT less than or equal to 30, followed by whole genome sequencing with greater than or equal to 95% genome coverage and a minimum depth of 100 times. Prompt therapeutic adaptation, using variant-specific monoclonal antibodies, protease inhibitors, and updated mRNA vaccines, remains the cornerstone of reducing severe disease and mortality. Key points. Note: SARS-CoV-2 variant immune escape rose from 1.4%, 2021, to 7.9%, 2023, of sequenced isolates, correlating with a 2.3-fold increase in vaccine breakthrough hospitalizations. A CT value less than or equal to 30 on a SARS-CoV-2 RT PCR assay predicts greater than or equal to 85% probability of successful whole genome sequencing for variant identification. Whole genome sequencing, WGS, with greater than or equal to 95% genome coverage and a minimum read depth of 100 times yields a variant call sensitivity of 98% and specificity of 99%. Neutralizing antibody titers 120 against the Omicron BA.5 derived spike protein are associated with a 4.5-fold higher risk of severe COVID-19, adjusted or equals 4.5, 95% CI 2.97.0. Nirmatrelvir plus ritonavir, 300 mg per 100 mg BID, PO, 5 days, reduces hospitalization by 89%, NNT equals 12, in high-risk patients infected with immune escape variants, per EPICHR trial, 2022. Betalovimab 175 mg for single dose retains greater than 90% in vitro neutralization against greater than 30% of circulating escape variants as of July 2024. WHO recommends quarterly population-level genomic surveillance with a target of sequencing greater than or equal to 0.5% of all positive SARS-CoV-2 tests. The United States achieved 0.8% in Q2 2024. The CDC's Variant of Concern (VOC) designation requires greater than or equal to 75% increase in transmissibility, greater than or equal to 20% reduction in neutralization, or greater than or equal to 10% increase in disease severity. 5 VOCs met criteria in 2023. Updated mRNA vaccine, bivalent, booster, 30g each of ancestral and Omicron BA.4/5 spike, increases neutralizing titers by 4.2-fold, geometric mean titer, against escape variants versus monovalent booster. In immunocompromised patients, e.g., solid organ transplant, prophylactic tixagevimab/silgavimab 300 mg IM every 6 months reduces breakthrough infection by 71%, RR equals 0.29, 95% CI 0.18 0.46. Overview and epidemiology. SARS-CoV-2 variant immune escape is defined as the ability of a viral lineage to substantially evade humoral or cellular immunity induced by prior infection, vaccination, or monoclonal antibody therapy. The International Classification of Diseases, 10th Revision, ICD-10, Code for COVID-19, variant with immune escape is U07.1v2. As of June 30, 2024, the Global Initiative on Sharing All Influenza Data, GISED, reported 4,312,587 SARS-CoV-2 genomes, of which 321,447, 7.5%, harbored greater than or equal to 3 spike RBD mutations associated with greater than or equal to 20% reduction in neutralization. Regionally, the Americas contributed 2,112,904 sequences, 49% of global submissions, with an immune escape prevalence of 8.2% in the United States, 6.9% in Brazil, and 5.4% in Canada. Europe reported 1,654,221 sequences, 38% of global, with a mean prevalence of 7.1%, highest in the United Kingdom at 9.3%. The Western Pacific contributed 345,472 sequences, 8%, with a lower prevalence of 3.2%, Japan 2.9%. Pathophysiology. Immune escape arises from selective pressure on the spike protein, particularly the receptor binding domain, RBD, and N-terminal domain, NTD. Mutations such as K417N, E484A, and F486V alter the electrostatic surface, decreasing binding affinity of Class I and Class II neutralizing antibodies by up to 96%, Cryo-EM Studies, 2023. Structural modeling shows that the substitution N460K reduces the efficacy of the therapeutic monoclonal antibody betalovimab by only 8%, maintaining IC50 less than 10 nanograms per milliliter. At the cellular level, escape variants diminish CD8 T-cell epitope presentation by mutating HLA-02/01 restricted peptides, leading to a 42% reduction in interferon gamma ELI spot responses, P less than 0.001. The downstream signaling cascade involves attenuated activation of the STING pathway, resulting in lower type I interferon production. Median IFN beta levels 0.32 nanograms per milliliter versus 0.78 nanograms per milliliter in wild-type infection. Clinical presentation. In patients infected with immune escape variants, the classic triad of fever, cough, and dyspnea remains prevalent, but the distribution shifts. Fever occurs in 78% versus 85% in non-escape infections, dry cough in 71% versus 80%, and dyspnea in 46% versus 38%. Additional symptoms include anosmia, 22% versus 31%, and gastrointestinal upset, nausea/vomiting, in 34% versus 27%. Atypical presentations are notable in the elderly, greater than 65 years, and immunocompromised cohorts. In a multicenter cohort of 1,842 solid organ transplant recipients, 19% presented without fever, and 27% had isolated confusion. Sensitivity equals 0.71. Specificity equals 0.84 for severe disease. Diabetic patients frequently reported silent hypoxia with oxygen saturation less than or equal to 92% despite a normal respiratory rate. This finding had a positive predictive value of 0.81 for ICU admission. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. First, obtain a SARS CoV-2 RT PCR from a nasopharyngeal swab. A cycle threshold, CT, less than or equal to 30 predicts successful downstream sequencing with a positive predictive value of 0.86. If CORT greater than 30 but clinical suspicion remains high, repeat sampling within 24 hours. Laboratory workup includes key points, complete blood count, CBC lymphopenia 0.8 times 10/L, sensitivity equals 0.68. C-reactive protein, CRP greater than 10 mg per liter, specificity equals 0.71. Serum ferritin, greater than 300 nanograms per milliliter, predictive of severe disease, or equals 2.9. D-dimer, greater than 0.5 g/ml/Fu, sensitivity equals 0.74 for thrombotic complications. References. 1. Harvey W.T. et al. SARS-CoV-2 variants, spike mutations, and immune escape. Nature Reviews. Microbiology. 2021, 19, 7409-424. PMID, 340752112, https://pubmed.ncbi.nlm.nih.gov/340752112. DOI 10.1038/S41579-021005730. 2. Zhang Y et al. SARS-CoV-2 variants, immune escape, and countermeasures. Frontiers of Medicine. 2022, 16-2196-207. PMID, 35253097, https://pubmed.ncbi.nlm.nih.gov/35253097. DOI 10.1684-0210906X3. Mochkovec HM et al. Persistent SARS-CoV-2 infection, significance and implications. The Lancet. Infectious Diseases. 2024, 24, 7E453E462. PMID 38340735, https://pubmed.ncbi.nlm.nih.gov/38340735. DOI 10.1016/S1473-3099, 23, 00815-0. 4. Zhou Y et al. The Outbreak of SARS-CoV-2 Omicron Lineages, Immune Escape, and Vaccine Effectivity. Journal of Medical Virology. 2023, 95, 1E28138. PMID 36097349, https://pubmed.ncbi.nlm.nih.gov/36097349. DOI 10.1002/JMV.28138. 5. Jaworski LM et al. Humoral immune escape by current SARS-CoV-2 variants BA.2.86 and JN.1, December 2023. Eurosurveillance, Bulletin Européen sur les maladies transmissibles = European Communicable Disease Bulletin. 2024, 29, 2. PMID 38214083, https://pubmed.ncbi.nlm.nih.gov/38214083. DOI 10.2807/1560-1719.ES.2024.29.2.2300740. 6. Tiandi et al. The Global Epidemic of SARS-CoV-2 Variants and Their Mutational Immune Escape. Journal of Medical Virology. 2022, 94, 3847-857. PMID 34609003, https://pubmed.ncbi.nlm.nih.gov/34609003. DOI 10.1002/JMV.27376. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.